He's also a student of Archana Vare, madam.
We are live, please.
A very good evening, everyone, and welcome to this fantastic episode of postgraduate case presentations. I'm Dr. Piyush Bansal, and I welcome you all along with Professor Archana Vare and the scientific committee. And we'll have two fantastic cases by our young residents. The first one being by Dr. Mansi Mahajan, ably mentored by Dr. Shubhangi Sathe, who's the HOD and professor at the Medical College Nashik, and of course Dr. Swati Zawar, assistant professor who took the efforts to make sure that their department is represented in the MOS program. We also have Dr. Pranali Deshmukh, who's a resident in the Government Medical College in Kolhapur, ably mentored by Dr. Abhijit Dhave, assistant professor in GMC Kolhapur. The pride of our examiners today is that we have Professor Anil Kumar Mondal, sir, who's there is nobody in the world who has more experience with pediatric glaucoma, with trab and trabs, with glaucoma in general. I was a student myself, and I am at loss of words when I think of sir. I've learned a lot from him, not just related to glaucoma, but life in general. I believe that he is Rabindranath Tagore incarnate, and we also have. So it's a great pleasure to have you, sir. Thank you so much for being over here and sparing your valuable time. He is an RPC alumni, and after having spent 35 years in LVPI and given so much contribution to pediatric glaucoma, he is now at Center for Sight in Hyderabad. And we have my dear friend, Professor Siddharth Kambre, who heads the Department of Glaucoma in Sri Ganpati Netralaya in Jalna. Thank you, Professor, for traveling as well as for despite traveling, you've been kind enough to accept our invitation to join over here. I'm sure the students are going to gain a lot out of it. We also have Dr. Preeti Kamdar, who's secretary of the Maharashtra Ophthalmological Society, astute glaucoma surgeon, a fantastic teacher. So I'm sure that everybody's going to gain a lot out of Madam being present over here as well. So with this, I hand it over to Professor Archana Vare to take the proceedings forward, and let's hope that everybody benefits out of it.
Yeah. Thank you, Dr. Piyush. So good evening, everybody. So we'll have two cases today. The first case will be presented by Dr. Manasi Mahajan, and we have around 10 minutes for presentation. And then from 8 to 8:30, Dr. Mansi will present, and from 8:30 to 9, Dr. Pranali will present. So we have around 10 minutes for presentation and 20 minutes for discussion. So I request Dr. Mansi Mahajan to share her screen and present her case.
Ma'am, is it visible?
No, doctor, not visible.
Okay. Now is it visible?
No. Or we can go ahead with Dr. Pranali's presentation, and 8:30 to 9, Dr. Mansi can present. Dr. Pranali? Yeah, now we can see.
Okay.
Yeah, we can see.
Good evening, everyone. Today, myself, Dr. Mansi Mahajan from SMBT, and under the guidance of Dr. Shubhangi Satya ma'am, today I will be presenting a case on primary open-angle glaucoma. A 60 chief complaint, a 65-year-old lady resident of Nandgaon is a homemaker presented to the ophthalmology OPD with chief complaints of diminution of vision since 5 years in both the eyes, the left eye more than right eye. Diminution of vision in both the eyes since 5 years, insidious in onset, gradual, progressive, left eye more than the right eye. No history of headache, nausea, and vomiting. No history of episodes of redness. History of usage of bifocal glasses since 5 years. Stopped using the spectacles currently as she wasn't comfortable. No other ocular complaints. Diagnosis of, she's a diagnosed case of primary open angle glaucoma using bimatoprost and dorzolamide eye drop in both the eyes since 5 years. As per the patient's history, she's compliant with her drops, but she does not have any prior records or perimetric reports available. Past history, patient has history of cataract surgery in both the eyes performed 8 years ago, 6 months apart. The postoperative period was uneventful with a good initial visual recovery. However, her vision began to deteriorate 3 years after the surgery. History of diabetes and hypertension since 10 years and on medication. She is using tablet metformin 500 mg BD and tablet amlodipine 500 mg OD. She has no history of bronchial asthma, coronary artery disease, cerebrovascular accident, Raynaud phenomena, migraine. A family history, no history of blindness of known or unknown cause in the family. Drug history, has history of using glaucoma medication since 5 years. Bematoprost 0.03% and dorzolamide 2% eye drop in both the eyes. History of using medication for diabetes and hypertension and has no allergy to any drugs. Personal history nil significant. General examination moderate build and nourish. Vitals pulse 68 per minute. BP 180 by 80 mm Hg. Afebrile. Systemic examination was within normal limit. Ocular examination. In the right eye, her vision is 636, improving to 69 with minus 1.5 spherical. In the left eye, it is finger counting at 5 meters, improving to 618 with minus 3 spherical. Color vision is normal in both the eyes. In the right eye, she has normal adnexa, conjunctiva, diffuse conjunctival congestion, cornea is clear. Anterior chamber, Von Erich's grade 4, iris normal color pattern, pupil is normal in size, circular, central in position and briskly reacting to light. She has a posterior chamber IOL with no PCO. In the left eye, adnexa is normal, conjunctiva with diffuse conjunctival congestion. Cornea is clear, anterior chamber, Von Erich's grade 4, iris normal pattern. Pupil grade 2 RAPD, and she has posterior chamber IOL with no posterior capsular opacity. In the right eye, applanation tonometry showed 18 mm Hg at 12:30 p.m. and in the left eye, it showed 20 mm Hg at 12:30 p.m. On gonioscopy, both the eye shows grade 3, that is open angle. Sclerosing were visible in all the quadrants, and no abnormal structures were seen in all the quadrants. Fundus examination in the right eye done with 90 diopter lens and slit lamp. Right eye showed glow red, media clear. CDR ratio 0.6 is to 1. Vertically oval cup. Superior rim thinning, no disc hemorrhage. FR dull. Mild attenuation of vessels, rest within normal limit. In the left eye, she had glow red, media clear. CDR 0.8 is to 1. Concentric rim thinning, laminar dot sign, bionetting of the vessels, peripapillary atrophy, no disc hemorrhage, FR dull, mild attenuation of vessels, and rest normal. Since we do not have the facility of fundus photo, I've tried to draw the optic disc. The visual fields were done for both the eyes. In the right eye, she showed moderate glaucomatous field loss in the right eye with inferior arcuate scotoma. And in the left eye, she showed total field loss, sparing a small central line. So my diagnosis is both eye pseudophakia with primary open-angle glaucoma with moderate vision loss in the right eye and advanced vision loss in the left eye. A plan of management for the left eye. The left eye shows advanced glaucomatous damage with visual field assessment done on 24-2 strategy. I would like to perform a 10-2 perimetry to evaluate the central field involvement. The intraocular pressure is 26 mm Hg, which is higher for advanced glaucoma. So in terms of management, I would either like to add a third anti-glaucoma medication or taking into account the factors such as financial constraints or the compliance. Given the advanced damage and need for lower target IOP, I would proceed with trabeculectomy to achieve a better long-term IOP control. In the right eye, she has moderate glaucomatous damage with an inferior arcuate scotoma on visual fields, and the current IOP is 18 mm Hg. I would like to perform a diagonal variation test to detect any IOP fluctuation or spikes that are missed. As the patient is hypertensive, I would also like to advise BP monitoring, and follow-up plan would be monitoring the disease progression with visual fields every 3 months. Thank you.
Yeah. Thank you, Dr. Pranali. Will you please stop sharing your screen? Yeah, thank you.
Yes.
So I would request Mandal sir to please ask questions to Dr. Mansi.
First of all, I want to know surgery when cataract surgery was done before that glaucoma was existing or glaucoma developed after cataract surgery?
So she had history of cataract surgery 8 years ago, and after 5 years, after 3 years of cataract surgery, she developed glaucoma.
So we do not know really, there is no documents whether glaucoma
No.
investigation was done before or not.
Yes, sir.
So when you saw the patient, patient had history of surgery about 5 years back.
8 years back, and
8 years
diminution,
back.
yes. And she was diagnosed 5 years
So,
back.
patient came with history of dimness of vision and problem, and glaucoma was diagnosed. So, what is your impression about the etiology of glaucoma? Is it primary open-angle glaucoma or related to pseudophakia?
So, since both the eyes are involved, it is less likely that it can be pseudophakic due to pseudophakia. And also, it would have developed immediately in the immediate or after 2, 3 years, and she would have realized it. But she has uneventful. She is saying that the post operative period was quite uneventful, and she was happy with the vision.
So, in the left eye also, she was happy with the post-operative visual outcome,
Yes, sir.
post-cataract surgery visual outcome.
Yes, sir.
Is there any document with her? How was the vision post-operatively after cataract surgery in both eyes, right eye and left eye, particularly left eye?
No, sir.
No. There was no evidence of any investigation, nor there is any clue about the diagnosis of pre-existing glaucoma or glaucoma after cataract surgery.
Yes, sir.
Is it possible? So what you feel, what must have happened? Glaucoma has been missed in this situation or glaucoma developed after this thing?
So since it is an advanced damage, probably it is missed in the early stages. If she was a mature cataract, if she was when she was operated, if she had mature cataract, probably at that time it could have been missed because of absent, we could not see the posterior segment. It also depends on which setup that she got operated. She said that she was operated in a CAM setup where probably these patients are not screened that well for fundus.
All right. So probably glaucoma was existing, but
Yes, sir.
fortunately, cataract surgery was uneventful according to the history and according to whatever records the patient had.
Yes, sir.
So the pressure in the left eye is still significantly high.
Yes,
What was
sir.
the when you saw what was the intraocular pressure?
So in the right eye it was 18 mmHg and in the left eye it was 26 mmHg.
You feel that whatever optic disc findings you presented and the field effect you saw, are they correlating clinically?
Mhm. So
Talk about right eye, then left eye.
sir, in the right eye, the fields are correlating, sir, I feel.
How?
Um, because she is also giving a history that she is putting already, she is already on anti-glaucoma drugs.
No, that is another thing.
Mm.
Using drug is something, and I want to ask you, any clinical feature is there which with which you can correlate the field effect with the clinical picture in the fundus, particularly optic disc evaluation.
Okay.
If I can remember, I saw the picture, right eye, you
Sure,
draw
sir.
the optic disc in a way that superior rim is
Superior rim
little
thinning was, yes, sir.
thinner. That probably reflected in the inferior
If
field
it,
effect.
yes, sir.
Is it not?
Yes, sir.
And left eye anyway, very advanced cupping and central island of vision.
Yes.
As you said rightly, the central field, 10-degree field should have been evaluated very, in the very first place. So how long you are with this patient? When you saw the patient first?
Sir, last week only.
Last week only.
Yes.
So this field defect which you presented has been done in your institute.
Yes, sir.
So in a situation like that, how you want to advise field defect? All patients should be 24-degree field, or depending on the clinical situation, optic disc appearance, you want to, in the very first place, 10-degree also.
Yes, sir. Looking at the disc, we should have done 10-2.
Ideally,
Yes, sir.
10 disc,
2 should have been
10
done.
degree visual field should have also been evaluated
Yes, sir.
in the very first place. Of course, in the overall management, the thing is so obvious, it doesn't matter. But, to really evaluate periodically in the long-term comparison of visual field, that is required.
Yes.
To assess whether the condition is deteriorating further or not.
Yes.
So what medication patient is on now?
Sir, she's using dorzolamide and bimatoprost.
All right. So on 2 medication, pressure is how much?
18 in the right eye and 26 in the left eye.
So what is the further plan?
Sir, since the pressure is higher and she has advanced glaucomatous damage in the left eye, probably I can add a third anti-glaucoma medication. But looking at her compliance and also the financial constraint, we can do trabeculectomy because it will control the IOP for a longer period of time. And in the right eye, I would like to first monitor her progression over fields. And since the IOP is 18, I would also do a diurnal variation test to see if there is any missed IOP spike.
All right, that's okay.
Yes.
But both the eyes pressure control should be better.
Yes.
Here optic disc is such, particularly in the left eye. The left eye probably will require surgical intervention, and the right eye probably supplementation further may reduce the pressure at a safe range.
Yes.
What you feel? What should be the safe intraocular pressure range in the right eye versus left eye?
Sir, we should set a target IOP. So for since it is moderate vision loss in the right eye, the target IOP should be something around 14 to 16. And in the left eye, since it is an advanced glaucomatous damage, it should be around 12.
So your impression is the patient will require surgical intervention, maybe first left eye and then consideration about the right eye
Yes.
also in future.
Yes, sir.
What is your uh, first choice? Surgical technique wise, would you go for implant surgery as it is done very frequently nowadays, or trabeculectomy?
Sir, actually, I don't know if MIGS will be like it can show proper results in pseudophakic patients. It is mostly done along with cataract. So I think we can do.
I'm talking about glaucoma drainage devices versus trabeculectomy.
Okay. Um, Sir, it is advanced glaucomatous damage and pressure is 26. So these devices will not bring the IOP level to the target IOP. It will not bring it down as much as required. Probably they will only bring the IOP to a certain level, but it is required to bring the IOP down to a much lower level. So
So
probably
if you do
trabeculectomy should be done.
if you do trabeculectomy, you will do simple trabeculectomy, or you will think for antimetabolite or wound modulation?
Antimetabolite.
What antimetabolite you will choose?
Mitomycin seems like.
All right. So you have examined the patient.
Yes.
The surgical technique was, can you tell or guess about the surgical technique for cataract? Is it phaco or SICS?
So there was no wound present, and it was a foldable intraocular lens, posterior chamber.
There was no written document. Oh,
No, sir.
no, there was no written document indicating the type of surgery.
No,
But
sir.
looking at the eye with slit lamp examination, can you
Yes.
guess what kind of surgery has been done?
Yes, sir.
What you feel? What kind of surgery may have been done?
Sir, there was no wound present, and the IOL was foldable IOL. On dilatation, it was a in-bag implantation, and it was a foldable IOL. So probably phacoemulsification was done.
All right. So in that case, have you seen any wound in the cornea, either in the upper part or maybe temporal side?
No, sir.
Have you
The
noted
history.
anything?
No, so the history was 8 years ago. So the cornea was clear,
No.
sir.
But for examination, with examination, even when it is 8 years back surgery done,
Mm.
probably detailed examination can really give some clue about the wound of
Okay.
entry,
Yes.
it, corneal, peripheral, clear corneal incision, or maybe scleral incision, self-sealing wound. Anyway,
Okay.
the reason I am asking is why I am asking this question, whether clear corneal incision or scleral tunnel incision has been given. Why I am asking this question? Can you guess?
So,
Because when you will do trabeculectomy, you will have to assess the conjunctival
suitable.
adhesion
Yes, sir. Mm.
in the sclera, in the
Yes, sir.
limbal region, whether conjunctiva is free in temporal section or even clear corneal section in the upper part, 12
Mm.
o'clock, conjunctiva will be okay. You can go directly through the
Yes.
limbus and do trabeculectomy. But if it
Yes.
is SICS,
SIC.
or for that matter, even if they go through scleral tunnel, you will have
Mm.
difficulty in making the conjunctival flap and do the surgery. In that
Yes, sir.
case, you may have to choose upper nasal or upper temporal area for the trabeculectomy technique. All right. So rather than asking many questions, I'm giving, my impression about how I'll go about it. Anyway, any
No,
question by other, Dr.
yeah,
Siddharth is
yeah,
there in the,
yeah.
Dr.
Dr.
Siddharth,
Siddharth,
you
yeah,
have any
Yeah,
question?
yes, yes, yeah,
your
yeah. You
questions,
hear me,
please.
Dr. Mansi? Yeah,
Yes, sir.
yeah. So you're a second year postgraduate student, right?
Third year, sir.
Third year, yeah.
Yes.
So I will ask few basic questions only.
Okay.
So, so you are diagnosed this case as a primary open angle glaucoma, right?
Yes, sir.
So what are the risk factors and pathophysiology of primary open angle glaucoma?
Sir, age. Age is a risk factor, race, then presence of diabetes, hypertension, cardiovascular diseases, then overtreatment of hypertension, hypothyroidism, Reynolds phenomena, migraine, then other factors, the pathophysiology is that it has two theories, that is mechanical theory and vascular theory. In mechanical theory, when there is raised IOP, it causes pressure over the lamina cribrosa and it causes ischemic damage of the axons, which will lead to retinal ganglion cell death. And in the vascular theory, there is ocular perfusion pressure is less, which causes the hypoperfusion of the optic nerve and causes the glaucomatous damages.
Family history, right?
Yes, pharmacist, yeah.
So coming to the disc findings, you have mentioned that there was a thinning of neuroretinal rim.
Yes, sir.
So the difference between thinning and notch.
Okay. Sir, in notch there is a diffuse diffuse
Notch and what is the neuroretinal?
sir, I can't.
Yes.
Dr. Siddharth, your question was not audible. Can you please repeat?
Yes.
Hello, Dr. Siddharth?
Yes, go ahead, Dr. Mansi. Yeah. Yes,
Your
yes, I'm here.
Yeah, we could not hear your question. Can you repeat the question, please?
What is the difference between notch and thinning of the neuroretinal rim?
Notch is when at a place the neuroretinal rim is completely thinned out, and thinning is only the the neuroretinal rim gets thinned out.
It's
Sir.
a complete loss of complete
Oh, yes.
yes,
Okay.
complete localized loss of neuroretinal rim is notch,
Yes.
and partial loss is a thinning.
Yes.
Okay. So what is the significance of disc hemorrhage or sphincter hemorrhage?
So disc hemorrhage is mostly tells us about the progression of glaucoma. It is mostly seen in normal tension glaucoma. It is seen in the inferior quadrant of the disc, and um, the presence is mostly telling us about the progression of glaucoma. Sir.
Okay, and what is the role of central corneal thickness in open angle glaucoma?
So, sir, if the central corneal thickness is more than the average value, it overestimates the IOP, and if it is thin, it underestimates the IOP.
Good. And how will you define target IOP?
So, target IOP is a range of pressure at which is set for a particular patient, taking into consideration multiple factors, at which further progression of the optic nerve damage is halted.
Dr.
Okay.
Siddharth? Yeah.
So if you of trabeculectomy.
Yes, sir.
Yes. What are the indications of trabeculectomy surgery?
Okay, sir, when the IOP is not maintained with at least three anti-glaucoma medication, and there is advanced glaucomatous damage, and we need to lower the IOP by a considerable amount. And if the compliance of the patient is poor, and also we should take into consideration the quality of life, or how much the patient is going to live for further years, and how much control the patient will be requiring. Mm,
And if you undergone the trabeculectomy surgery,
yes.
so post-operatively, what are the things you will look to see for the health of the blade? I mean, there is a grading of,
Yes, sir.
that theoretical, it's a theoretical
Yes, sir.
question.
So we
Indiana
look at
grade.
the height of the bleb,
Four things. Yeah.
the height of the bleb, the vascularity of the bleb. Um,
One is height. Second is
vascularity.
extent of the
Okay,
blade.
extent of the bleb. Yes.
Third is vascularity.
Yes.
And fourth is
The
leakage.
leakage.
Right.
Yes, sir.
Okay. Okay, that's all from my side.
Yeah, thank you. Thank you so much, Dr. Siddharth. And now we will move on to our next case because it's 8:30 now. So I request Dr. Pranali Deshmukh to share her screen and start presenting.
Yes, ma'am.
The screen is visible, but please make it
Yes.
yeah.
Okay. Okay. Good evening, everyone. I'm Dr. Pranali Deshmukh, Junior Resident in RCSM GMC, Kolhapur. My mentor is Dr. Abhijit Dhave, Assistant Professor. First of all, I want to thank Mos for giving us opportunity to present the case. So let's start with the case details. Parents first brought patient to ophthalmologist at 4 months of age with complaint of large eyeball, intolerance to light, and bluish white discoloration of eyes since 2 months. Instead of presenting illness, my patient was apparently all right until 2 months of age, following which parents noticed gradual onset of enlargement of both eyeballs, bluish discoloration in both eyes, and intolerance to light, which was progressive in nature. Patient was initially taken to general practitioner, but definite treatment was not given. So subsequently, at 4 months of age, he was brought to ophthalmologist for further evaluation and management. Birth history, it was full term cesarean section delivery. Baby cried immediately after birth. Birth weight was 2.5 kg, and there is no history of birth trauma or torch infection. Vaccination was completed as per schedule for that age. There is negative history for glaucoma and no history of consanguineous marriage. So ocular examination or at 4 months of age, vision we could not assess that time. Lid and conjunctiva were normal. Corneal edema present in both eyes. After that, we examined the patient under general anesthesia. So IOP in right eye was 40 millimeter of mercury with axial length 20.3 millimeters. Corneal diameter is 13 mm. Anterior chamber was deep, and iris and pupil were hazily seen in right eye. Left eye IOP was 40 millimeter of mercury. Axial length was 20.1 millimeters. Corneal diameter is 13 mm. Anterior chamber is deep. Anterior chamber was deep, and iris and pupil hazily seen. Rest anterior chamber details and fundus were not visible due to corneal edema. After we confirmed the diagnosis of congenital glaucoma with EUGA, patient first underwent trabeculectomy with trabeculotomy in right eye first on 20th of February 2020, followed by same procedure in left eye on 5th of March 2020 after interval of 15 days. During 15 days of interval, patient was maintained on eye drop brinzolamide. On post-op day 2, corneal edema was reduced, eyeball digitally felt soft, and patient was discharged on topical antibiotic steroid combination and cycloplegic drugs. After that, patient was lost the follow-up because COVID-19 happened, and they came after 6 years, and they did not keep the follow-up. So these are the findings. Head posture was normal, straight ahead. Facial symmetry symmetrical. Forehead normal. Extraocular movements were normal, full and free in all directions. There is right eye exotropia, approximately for 15 degrees. Examination at 6 years age, best corrective visual acuity in right eye was counting finger 2 meters, and in left eye it was 6 by 9. Lid normal. In conjunctiva, diffuse avascular blood present in both eyes. In right eye, in cornea, horizontal corneal scarring present with corneal diameter is 14 mm and central corneal thickness is 641. In left eye, horizontal corneal scarring present with corneal diameter 13.2 mm with CCT 580. Anterior chamber is deep. And iris, in iris, peripheral iridectomy present at 12 o'clock with color pattern normal in both eyes. Pupil were circular, 3 mm in size, reactive to light. Intraocular pressure measured at 1 p.m. with non-contact tonometer. In right eye, it is 11 millimeter of mercury, and in left eye, it's 16 millimeter of mercury. Axial length in right eye is 24.14 millimeters, and in left eye is 23.10 millimeters. Dilated examination was done by direct and indirect ophthalmoscope with 20 D lens. Media is clear, optic disc normal size shape and pale in color. Cup disc ratio in right eye is 0.8 to 0.9 with nasalization of blood vessels. Foveal reflex was dull and periphery normal. In left eye, optic disc normal size shape and with pale color. Cup disc ratio is 0.6 to 0.7 with nasalization of blood vessels. Foveal reflex is dull and periphery is normal. These are the right and left uh, slit lamp photographs. As we can see, cranial scarring with peripheral at iridectomy at 12 o'clock. These are the fundus pictures. So my diagnosis is both eyes primary congenital glaucoma, surgically managed with combined trabeculectomy with trabeculotomy in both eyes, with right eye exotropia 15 degrees, presently maintaining normal intraocular pressure. Thank you.
Yeah, thank you, Dr. Pranali, for that nice presentation. Yeah, I request you to stop sharing your screen. Yeah, and I request Mandal sir to ask questions to Dr. Pranali.
Maybe I'll comment later. Why don't you ask the other doctor? Doctor
Siddharth, Dr.
Yes,
Siddharth.
Dr. Siddharth, you can
Yes,
start.
sir.
Yes.
Yes, sir. Yes, sir. Yeah, Dr. Pratali, nice presentation.
Thank you,
Uh,
sir.
regarding primary congenital glaucoma, so there are typical signs, right? So what is that classical triad of typical symptoms of the patient?
Photophobia, watering, and blepharospasm.
Okay, if fora watering, what is the reason of PP fora?
Um, because of
Corneal epithelial edema will be there, no?
reading.
Which will cause irritation of to the patient. Okay, so coming to the differential diagnosis of PP fora watering, what are the DDs of PP fora in newborn child?
In pediatric or in newborns,
Newborn,
nasolacrimal duct obstruction, then conjunctivitis, ophthalmia neonatum, or corneal abrasion can
okay,
cause
any
what?
birth trauma.
Yeah, in birth trauma, during
Okay.
birth trauma.
How we will differentiate NLD block or nasolacrimal duct obstruction from EP4 due to congenital glaucoma?
Um, there
What
will
kind?
be fullness or swelling near the medial canthus.
Okay, photophobia will be absent in NLD obstruction,
NLD
right?
obstruction, yeah.
Yes. Cornea will be mostly clear.
Yeah, in NLD obstruction, cornea will be clear, and in congenital glaucoma, corneal edema is present.
Yes, in NLDO, eye size will be normal,
Yeah,
and
yeah,
even intraocular pressure will be normal, right?
yeah.
Okay. So, if you diagnose the CD ratio, cupping will be there, and if you treat it early to the patient, and what will happen to that disc if you treat that patient early?
Changes can be reversible if
Why it
we
is
treat
so?
early.
Why it will be so?
Uh,
What is the pathophysiology behind that?
Pathophysiology, sir, in collagen fibers at lamina cribrosa are immature and
Elastic. Okay.
elastic, and because of raised IOP, um,
Yeah.
uh,
That elastic lamina cribrosa allows that reversal.
reversible changes.
Okay. Mm. So, okay. So, which surgery you are undergone? Trab or trab, no?
Yes, trabeculectomy with trabeculotomy.
So, are there any indications for the surgery if the cornea is clear or cornea is hazy? If cornea is
Yes.
clear, you have one more option of surgery.
Goniotomy.
Yes,
Uh,
surgical
we can do
goniotomy.
goniotomy when cornea is clear.
Right. And when cornea is hazy, then trab is the better option. Okay.
Yes.
So, what is the principle of trabeculotomy? Trabeculotomy.
Trabeculotomy. Sir, we partially made a scleral flap, and then through Ham's trabeculotome. We we inserted the
I'm not
Ham's
asking the
trabeculotomy in Schelm's canal, and then we open into the anterior chamber. So there will be a physiological passage for aqueous drainage. We created a
right.
physiological passage for aqueous drainage.
That the basic principle is you are opening the Schlemm's canal externally to bypass the abnormal trabecular meshwork.
Yes.
Okay. So, what is the role of medical therapy in congenital glaucoma?
No, sir. Surgical management is the treatment of choice. There is very limited rule for medical management.
To control the IOP temporarily.
Temporarily, yes.
Okay. So, which are the anti-glaucoma medications you can prescribe?
Brinzolamide or dorzolamide are the drug of choice in
Beta,
pediatrics.
even beta blockers,
In beta blockers.
topical carbonic anhydrase inhibitors. Okay. Okay. So, what are the differential diagnosis of HABS trial? HABS trial, how they look?
Habs are
How they are seen?
curvilinear, horizontal, along with the limbus, and
Mhm.
they can differential diagnosis for that is um, birth during birth trauma there can be a vertical corneal aberrations.
Yeah, they will be vertical.
Vertical corneal, those
They
are
will have
vertical during the birth trauma, and
horizontal.
habs are horizontal.
Yes.
And there is normal intraocular pressure during in deep vertical
And what are the differential diagnosis for ophthalmos or large eye?
megalocornea,
Hmm.
then megalocornea, large eye, and congenital high myopia.
Right.
Um,
Again, even bird trauma, Descemet's tear will be there. Even Sturge-Weber syndrome, which will cause again secondary glaucoma. Right.
Yes, sir.
Okay. Okay, sir. That's all from my side. Please go ahead.
Okay,
Thank you,
Siddharth, thank you. Pranali, can you tell me, before really deciding for surgical intervention,
Yes, sir.
what are the things you want to make sure that you are not doing any mistake? Or what are the precautions? And make sure that your decision is correct for surgical intervention.
Before surgical intervention.
Before surgical
Um,
intervention, be it goniotomy, be it trabeculotomy alone, or be it combined surgery, trabeculotomy, trabeculectomy, before surgical intervention, what are the things you want to establish? You want to establish the diagnosis.
yeah.
Yes. You want to rule out certain things. What are those?
So first, we need to examine the patient under general anesthesia for we need to check axial length, corneal diameter, and
I'm giving a clue that whatever you are thinking, bilateral or even unilateral congenital glaucoma, that may not be primary congenital glaucoma.
yeah, we need to first make sure it is primary or it is secondary, and with is it associated with any other ocular any other ocular abnormalities or syndromes, congenital,
Like,
uh,
like
like Peters anomaly or Axenfeld-Rieger syndrome or aniridia or
that
syndrome,
that
systemic syndromes
that
like
that you
Sturge.
will be able to diagnose when you are doing anterior examination or under microscope.
Sorry, sir. I could,
That will be evident when you are examining under microscope with magnification, aniridia, your
yeah.
Axenfeld-Rieger anomaly, etc., will be visible. But more than that, what else you look for? Maybe in the fundus.
Yes. Optic disc.
If the fundus if the corneal clarity permits.
No,
Even if
because
cornea is little hazy, you should do ophthalmoscopy, particularly with indirect ophthalmoscopy. And if the cornea is totally hazy, what you should do? Would you like to rule out any significant, maybe dreadful disease, which may not be related to glaucoma to start with, but later on it can give rise to intractable glaucoma?
I could not
Any
read.
posterior segment pathology? Very simple clue. And you should not be scared.
Malignancy or any
So, if the cornea is totally hazy, you should think of that condition also. It
yes,
can happen
tumors.
unilaterally, it can happen bilaterally. And that's the reason what investigation, if you cannot see or
B
examine
scan.
fundus with the help of standard examination.
B scan.
So, have you done B scan in this patient? Or in this patient, cornea was reasonably clear to do fundus examination? So, wherever necessary, wherever possible, I'll say practically in all cases, it's a good idea to do B scan to keep a record that you looked for it and there was no problem.
Yes.
Because there are incidents, there are evidences in the literature that secondary congenital glaucoma because of retinoblastoma, the most common primary intraocular tumor in that age group is retinoblastoma.
Retinoblastoma.
And that was missed and surgery was done. There are several such reports, I'll say, very unfortunate report actually, unfortunate situation which has been reported, it can happen. So that's a possibility and you should rule out that.
Yes.
Another thing, you want to do surgery, but you want to make sure that there is no other source of infection in the adnexa
Yeah.
or in the
Congenital.
conjunctival sac,
Congenital.
particularly most commonly congenital nasolacrimal duct occlusion. You should be very careful and make sure you note it very carefully, document it very carefully. So, any other thing? Documentation of all, I'll say, dimensions, corneal diameter, optic disc cupping, wherever it is possible, and gonioscopy. Gonioscopy was done in this patient?
Yes, sir. That time, I
Yes.
guess.
What kind of gonioscope was used?
Direct.
Direct. What's the name of the gonioscope?
Copays.
Huh?
Copays.
Cope. Have you seen Cope lens?
No, sir. I never seen.
You have never seen.
Yeah.
You are telling that your Cope lens was used for
No,
this
these are the
patient?
records.
Huh?
Surgery was performed 6 years back, so
Oh, you are not there. Sorry.
yeah, I was not there. So
In
I.
department Cope lens, Cope, Koeppe. Actual pronunciation is Kepe. Kepe lens. Kepe lens is there in your department?
Mm,
All right. So you should see the picture, read at least theoretically. It's very important investigation for primary congenital glaucoma or any pediatric glaucoma for that matter to understand the etiology of the uh, pathology, know the etiology and pathogenesis of the condition.
yes.
So you have done, yeah, you saw the surgery was done and ultimately patient was lost to follow up for 6 years.
Yeah.
What happened to the patient, we don't know. Whether they consulted any other doctor locally or
No,
no idea.
no idea, sir. There was no record.
But ultimately left eye was having reasonably good vision, right eye having exotropia and poor vision.
Yes.
Right eye was the more severely affected eye,
Yes, sir.
finally, at least at the present time when you have examined the patient.
Yes, sir.
Have you examined the patient?
Yes, sir.
Have you seen the patient?
Sorry? Yeah, I have
You
seen
see
the patient. Yes, sir.
What's the age of the patient now?
Now he's 6 years. He's 6 years
6
old.
years. So, so bilateral, bilateral. So the question is, ah, so visual acuity is the left eye is how much?
6/9.
6/9, and other eye, right
Counting
eye,
finger 2 meters.
advanced. All right. Is the patient using any medication now?
No, IOP is controlled, so he's not on any
What was
medication.
the IOP in the last visit?
11 in right and left eye, it's 16.
Left eye,
It's 16.
16. It was done under anesthesia.
No, no, no. A non-contact tonometer.
What tonometer was used?
A non-contact tonometer.
6-year-old child. Extremely difficult to record intraocular pressure without anesthesia. At least in Indian circumstances, most of the child, according to my experience, 6-year-old child, extremely difficult. And the results we get depends on the cooperation of the patient. Yes, I'm not telling it is not impossible. It is possible. But the cooperation of the child should be there. And yes, slit lamp mounted applanation tonometer or even Parkin's handheld applanation tonometer can be used. So, have you read about surgical technique of congenital glaucoma? How I'll say old is the history of surgical treatment. Surgical treatment started when in the history of congenital glaucoma. Uh,
History.
you read about the surgical treatment from the textbook, either Baker Shepard or Bruce Seal, just to know that probably, why probably, exactly, before 1938, there was no treatment. Invariable result was blindness. You know, the goniotomy technique was described by whom?
Barkan.
Barker, Otto
Yeah.
Barker from San Francisco, the year 1938. When was the surgical technique of trabeculotomy, external trabeculotomy described?
Who described? Uh,
When was that? Which year it was described? Who
mm,
described will be a little
Arms
difficult.
and Dunham
Huh?
describe the
Burian and
technique.
Allen. Burian and Allen. Hart described much later. He devised the instrument, modified. In the year 1960,
Yes,
all
sir.
right, this is acceptable. Trabeculotomy description in the year 1960. If you do not know, but read it.
Yes.
But you must answer when was the trabeculectomy described for the first time in the literature. There is no mercy for that. You'll have to answer correctly.
In
Archana, am I correct in the decision-making process?
Yes, sir.
In the MS exam, you will have to answer trabeculectomy surgery, in which year it was described.
So Pranali is doing very well, sir. Thanks to you,
Huh?
sir. Pranali is doing very well, sir. Thanks to you.
All right. If you do not know, I'll not tell the answer. Read from the textbook and tell your mentor that you have read it. And this is the answer.
yes.
Okay? Because after all, trabeculectomy, be it adult, be it pediatric glaucoma, be it adult glaucoma, that is the most commonly performed surgery in the subspecialty of glaucoma. Is it not? Trabeculectomy. All right. I'm just telling the year, 1968.
1960.
Okay? Rest you should read from the textbook. I think time is up. Archana,
No, sir, we still have,
final conclusion?
no, sir, we have time for 5
You have
minutes.
time, 2-3
Yeah.
minutes more.
Yes, sir.
So I think you can conclude the session from your side. Please.
Okay, so today we were fortunate, very, very lucky to have Anil Mandal sir with us. And I'm really thankful to Dr. Anil Mandal sir for sparing his time with us. And I'm also thankful to Dr. Siddharth Kamble for his time. And both the students, Dr. Mansi as well as Dr. Pranali, they had fantastic presentations. So I'm thankful to their mentors, Dr. Sathe ma'am and Dr. Zawar ma'am and Dr. Dhavle sir. And I request Dr. Piyush Bansal, who's the chairman of Scientific Committee, Maharashtra Ophthalmic Society, to give the concluding remarks.
Thank you, ma'am. I think you've already concluded it. I will just like to thank Sunilji. Thank you, Sunilji, for helping us with this webinar. Thank you to Entored. But most of all, to the lovely residents, Mansi and Pranali, you did so good. I'm so proud of you.
Yeah, they did very well, actually. Scope for improvement is always there. Both of you are in the third year of your MS?
Yes, sir.
Yes,
Okay.
sir.
Okay, very good. So when is your final exam?
We have it in September, sir.
Very good.
This year,
September.
26.
Yes,
So
sir.
there
September
is
is
some
their
time you should be able to read further.
Yeah.
And
Okay.
a big pranam to
Are namaste, namaste.
Anil
You,
Kumar Mandal, sir.
very good.
Yes.
My
And
pleasure.
thank you
My
so much,
pleasure.
sir. Thank you so much.
I
You guys are
remember
really
my PG.
lucky.
I remember my PG days in RP Center
Sir,
from 1984 to 1986.
sir,
84, 5, 6.
sir.
And
I was
then
I was just born that time,
next
sir.
3 years, my senior residency.
Sir. But
All right.
Mali and Mansi, you guys are so lucky. You know, we don't realize the importance of things until we start practicing. You
Yes.
guys are residents right now. Maybe you will pick up glaucoma. Maybe you'll pick up some other subspecialty. But these points are always going to be there with you, which Dr. Siddharth, Dr. Mandal, Dr. Abare, everybody. You know, we are a collective effort of everything that we learn from so many places. And everything that we can touch, every patient that we can touch and benefit, that is the goal. So you guys are very lucky. Thanks to Professor Mandal, sir, and thanks to my dear friend, Dr. Siddharth Kambe. Professor Siddharth, he had some fantastic questions. And all thanks to Professor Archana Vare. All thanks to
Very
her.
good. Very good. So, glaucoma, the volume is so much to do. We want to inspire the next generation of professionals to take interest in glaucoma. And of course, there is cataract tag to it. So no problem, don't worry. Your financial aspect will be looked into. And we want to inspire for people, junior generation of people to take interest in pediatric glaucoma. We have the largest volume of patients of pediatric glaucoma in the world. If you read an article published in Ophthalmology Glaucoma 2 years ago by Pediatric Ophthalmology Glaucoma Society members, and in a year, the volume is so high, and we require many more specialists, particularly to take care of the pediatric glaucoma patients. So we want to inspire both of you to think over it. Okay?
In fact, it's because of
Yes.
Mandal sir that I will now share a story that I generally don't tend to do. I have a lot of stories from every day, but I had the chief of retina services in one of the Arvind Eye hospitals calling me. And Sunilji, if we can go